surface antigens, core antigens, all this stuff. We're going to break it down. So disorders of the liver, part 2, hepatitis, very exciting. So break that down. Acute versus chronic. Heterotrophic viruses breaks down into what? How many flavors of hepatitis are there? If we're talking about heterotrophic. Yeah, we're talking about 6. So there's 5 main, and then there's the other one, the hepatitis G, which is like a back and forth. It's like GE-C, whatever. It's all wonky. I wouldn't get too wrapped around the axle about G. It's not a big deal. But then we can have other etiologies that are causing that. Like 3 or 4 flavors there, bacterial, fungal, parasitic. Viruses, those all cause opportunistic infection. And then our non-infectious with alcohol probably being number 1, the drug abuse, and the autoimmune hepatitis. We're going to get into all those specifically. Here's your main. So your main 3, A, B, and C. Those are probably the ones that I would spend a lot of my time focusing on. There's a good portion of the test that is over these next 2 lectures. Good portion. I'd say probably the majority of the test is on these next 2 lectures. So, want me to slow down now? So, there's your replicas. Replications that starts with, but here's our heterotrophic viruses, similar pathological pattern. So that means all these viruses act similarly when they show up. These 4 phases, we'll get into each phase. I would definitely know these phases and how they present. Definitely know these phases and how they present. So you've got your replication phase, usually asymptomatic during this time. Asymptomatic. So laboratory studies can demonstrate some markers of hepatitis very early with that, but this is our viral replication phase. This can happen anywhere from 2 to 3 months that somebody's infected that they don't even know it. Don't even know it. Then we move into prodrome. As that obviously says, so we're going to have blue light symptoms, this anorexia, nausea, vomiting, I just feel bad. Maybe I have some urticaria, which means just wheeling in the body, so there's some type of histamine response. And then itching of the skin with pruritus. And then it's kind of weird, alterations in taste. So if these people are smokers, they suddenly come in and say, I don't want to smoke anymore. That doesn't mean that you go, do you want some Chantix? Do you want nicotine replacement? Do you want hepatitis? That's not the option. That's not the option. So, okay? And then we have our icteric phase, kind of runs along with the lines of icterus with the eyes. So a lot of gastrointestinal symptoms, but the biggest thing we're going to see is that jaundice. When we start seeing jaundice, we know that we're having an increase in what in the body typically that causes the jaundice? Bilirubin. So if we're having bilirubin, we're probably going to have dark urine followed by pale colored stools. Very similar to what we've seen before when we were talking about a biliary obstruction, right? It's going to push all that bilirubin to the kidneys, it's going to show up in the urine, it's not going to go to the GI tract. So same thing here, malaise, and then white upper quadrant pain. Hepatomegaly, all right, so maybe they are going to make a justification for why you should percuss the liver and determine what the size it is. Maybe, but I'd probably let an ultrasound get it for me. So then your phase 4 is your convalescent. This is their recovery phase. So most of this stuff they're going to resolve versus going into chronic, so liver enzymes are going to drop back down to normal. Now we're going to go in order, A to B. A, second most common. Second most common. So that has been a significant decrease, though, since we vaccinate for A and B typically before you're the age of 10. So this is a fecal to oral transmission, so usually from eating bad foods, contaminated foods or water, or travel to endemic third world countries where this is a little bit more prevalent. With Hep, right there, 30-day incubation period. That's that viral replication phase. And then right away, they're usually, before this 2 weeks is up, are already shedding the virus, which means they are contagious. Very early in the disease process. They haven't even started having symptoms yet, and they already have the ability to infect other people. So we don't get too fired up about hepatitis A, right there, low mortality, but it can progress to fulminant disease, but very rare. Very rare. We do get concerned with because Hep A will run with Hep C. Then we need to be a little bit more concerned. If you have 2 hepatitises, I think naturally it's going to be more concerning than only having 1. It's like my 2 ex-wives, whatever. So we get 30-day incubation period. Worry about hepatitis C. 4 weeks post-exposure, that's when the symptoms start showing up, so we're starting to hit a little bit, kind of bypassing that prodrome phase, going right into the icteric phase. We're going to see malaise, myalgia, arthralgias. Upper respiratory symptoms can run with this as well, which can definitely kind of muddy up your clinical suspicion. So, but we have anorexia again, that disdain suddenly for cigarettes, and then fever breaks, and then the jaundice starts, and we get definitely into that icterus phase right there. So it starts on the tail end of that. So a lot of times they get mistaken for a viral gastroenteritis versus a viral URI. So we do need to ask those folks, where have you been? Any recent travel? Are you drinking water that wasn't purified? Or are you eating food from some weird places? Not super common, but can happen. Again, very similar for all these hepatitis. So dark urine with pale stools. Dark urine with pale stools and progressive improvement. So the course of this is typically only 2 to 3 weeks, very self-limiting. No progression to chronic carrier state. So we don't get too fired up about hepatitis A, but we need to know that. What do we see on labs? Obviously, markedly elevated AST and ALT, but we're also seeing bilirubin and alk phos. So we obviously need to be thinking like, oh man, this is kind of presenting like maybe an obstruction, or is this liver disease? We have to work those out. We have to have an idea. So we need to get the anti-HAV antibodies up here. So the IgM that's going to show up with that, which is going to show more of an acute infection. And I'll explain that a little bit more. And it's acute infection, that gives an idea of acute illness. So if it's IgG, we're going to be looking at something that's more of a chronic type of illness. So IgM is like confirmation for most of these hepatitis. Why? I'll show you that right here. So peak in the ALT, so it's like, okay, what's going on? Definitely something going on at 3 to 4 weeks. Symptoms are still continuing, we need to work this up. You see how that IgG kind of shoots up, going up there, much higher tier where the IgM gives us that acute phase going along with that ALT. That IgM, if they follow that course, they're going to be an acute course. They can very switch off and go to that IgG course. We want to check those things with antibodies. They are in more of a chronic phase. IgG chronic, IgM acute. And that's going to be with most of the hepatitis that we get into. Now hepatitis A, not too crazy, but definitely hepatitis B, we're going to get deep, and that was what that video was. So symptomatic care, bed rest, probably going to put them on quarters. We give them antiemetics for their nausea, vomiting, antidiarrheals for their increase in bowel movements, lots of fluid. They may need to stay away from work or strenuous exercise. So, and the post-exposure vaccination, if it's not previously been vaccinated, that person needs to go. Keep in mind, there are pockets in the United States where they have people that are anti-vaxxers. And vaccines, if you run the numbers and what vaccines actually take care of for people, you would give everybody a vaccine, even if you believe in that potential conspiracy theory or theoretical theory that is caused by mercury in the vaccines is causing autism. What it's saving, if we get a couple kids with autism out of it, so be it. But what it's saving lives across the world when you look at those types of things. So we encourage those people to get vaccinated. And then we're during this rest time, no alcohol, and we avoid any medications that are hepatotoxic. Questions on A? Questions on A? I'm not trying to give anybody opinions on anti-vaxxers. I'm just saying you're going to have pockets of people that you're going to deal with that. And if we're anywhere near a border town and you have any illegal immigrants come up, your differential just went like this. Okay? You need to be careful about that. You are going to get tested on those things anyway. All these hepatitis and shingles and measles and German measles and all that stuff. So save that for next semester. So hepatitis B, usually from inoculation infected blood or products. Why do I say this is important? Because that's potential for you. An accidental needle stick from a patient that has hepatitis B can risk you getting hepatitis B. So that's why I tell you this. You need to be aware of that. This is a big issue with that. So sexual contact as well, we see that in saliva, semen, or vaginal secretions. And then this is potential that mothers that have this, it can be passed on to the fetus. Can be passed on to the fetus. They will screen a lot of these things. So variable presentation, meaning it can be anything from mild to very severe. So, and then it's just one that can easily transition to chronic. So who, this is important to you. So healthcare workers, you get an accidental stick in the hospital, you need to go to the emergency department. They're going to order a bunch of tests on you to make sure that this isn't something that you're going to get dealt with. So staff at hemodialysis centers, yes, because they're exposed to a lot of blood product. We have our IV drug users and our prisoners. So I imagine the prisoner stuff is probably a mix of sexual content and potential IV drug use. So screening recommended for your high-risk groups and people that work in these areas potentially. So incubation period, this is crazy. Anywhere from 6 weeks all the way to 6 months. That incubation period, that's that viral replication period. So substantial risk for cirrhosis and hepatocellular carcinoma. That's why we get worried about these. So much like alcohol does the same thing, hepatitis B does it as well. So increase in men over women. Very similar in clinical syndrome procedure or presentation. So also similar to seeing what we see in HAV. And greater elevations in AST and ALT. We give you an idea that maybe this is an alcohol-related thing. But here's where we start getting into the serology of this. You must understand this with hepatitis B. It gets really weird with what's antigens and what's antibodies. So what's antigens and what's antibodies. We know what antigens are, did we jump that already from micro? The antigens just show up to attach the things to let the antibodies know that it's time to get their game going. It's a warno, if you will. So different situations. Here's what I need you guys to know. So surface antigen, that tells us that that person potentially has HBV. So hepatitis B potentially has that. Well, what's going to happen is you have the antibodies that show that. That's going to tell me exactly that I know that that person had HIV, but had hepatitis B, but they cleared it, or this person has been vaccinated. And I have some cool charts here that can kind of break this down so you understand. We just need to know that if we have antibodies to the surface antigen, then we know that that person has either been vaccinated or has cleared the infection. Has cleared the infection against hepatitis B. So hepatitis B, here's the core antigen. That's great. They can do a biopsy and potentially find that. Doesn't matter for us. Core antigen, we're not going to see that. That is not detectable in the serum. I can't tell you in the next 5 years if we don't come enough medical technology that we can't figure that out. But for right now, the answer is not detectable in the serum. But you have the antibodies there. Antibodies that are going to show up. Appears after that is detected. So that's going to give us an idea that if we have that going on, then that's almost confirmation for us. That's confirmation. But then we have to take it to the next level, which I said we get an IgM or an IgG. IgM is acute. IgG is going to tell us that maybe this has been going on a lot longer and it's getting chronic. Chronic. We can see that right at the bottom. IgG, anti-HBC, that's the core antibody versus IgM. So IgM again. Acute, IgG is going to be chronic. So here's the other thing is the E antigen. So we want to get this potentially older folks that are having issues. This is going on a lot longer. If they're still having these types of symptoms, we're like, what's going on? They're still jaundice. It's been 3 months. Well, if we check this, it's going to give us a much better idea that now it's gone back into viral replication. So it's gone through those full processes. Viral replication, it's gone on to prodrome, it's gone on to Icteric. They had a recovery, but now it's gone back into viral replication, which is going to run through the whole thing, and now we're in chronic phase. This really helps. Right after that, IgG, we get this, and that completes that. And we get an HBV DNA as well. Here's a great slide just to break that down for you. So if you don't like looking at those slides, we can go right here and pay attention, and it's just going to kind of break things down. Obviously, anybody that doesn't show up with any antigens or antibodies is still susceptible. Because they've never had an exposure, they've never been vaccinated. So, whereas we go down there a little bit. So if somebody had natural infection, meaning they had actual hepatitis B, contracted it, they're going to have both antibodies. So, and if you had just the vaccine, you're going to show up with antibodies for the core. If you had just the vaccine. So I would review those, and then it gets a little wonky down to the bottom. I'm not going to get into weeds on you guys on the test. So do they have it, do they not? I'm just as confused with that video. So be it. But for you visual learners, if you want another one, I really like this slide as well. What I want you to pay attention to is everything that says IgG is chronic. So everything that says IgM is acute. That's what I want you to take away from this slide. What I want you to take away from this slide. Like more visual stuff right there. So again, this is hepatitis B with recovery. So this person did not develop a chronic hepatitis B. So we see what's going to help us give an idea there. Surface antigen is showing up. Surface antigen is showing up. And then we have the IgM that runs a little bit longer that's going to give us the idea that they have an acute infection. And then the antibody for the HBC, the core antigen, is the confirmation test. 100%. We have those three. So antibody HBC confirms. And then that total antibody HBC is going to give us an idea that they are going into recovery. Because why? What would we see added on there potentially? I'll show you that here in a minute. So supportive treatment again, antiviral for people that have severe disease, people that are already immunocompromised. Maybe that person already has underlying cirrhosis or other problems with their liver or carcinoma. So we get very concerned about that progressing to encephalopathy and coagulopathy. We'll get into that a little bit later. Usually prognosis, critical illness, 2 to 3 weeks, complete recovery within 4 months. Careful with that, screening for donated blood, serology testing during pregnancy, safe sex practices, safe handling of blood, bodily fluids, and then we want to come back around to that vaccination. So there is a hepatitis B immunoglobulin that's for known exposure. That is going to be a healthcare provider. That's what they're going to give them, healthcare provider. They're going to test the patient's blood, they're going to test their blood, and they can potentially give this, and then you get a vaccination after that. So here is your progression to chronic. So we know that that's going on. The HSV starts off right away. We have the total antibody HBC, which confirms that it's chronic because that surface antigen still is in play. It doesn't go away. The surface antigen is still in place, which means we have active infection through that whole time, progressing into years. I've been tracking on that, understand. That surface antigen is supposed to go away. If we're testing positive and we're looking at still testing anywhere from 24 to 36 months, 2 to 3 years later, and they're still showing up with that surface antigen, we need to be very concerned that this person has developed a chronic and it's continuing to replicate. All right, hepatitis C. So 50% of these people, IV drug users. We're at risk of a whole bunch of things with your IV drug users, but we have transfusion infected blood. This is the one you tell people about. Make sure you check your tattoo shop before you go. And hepatitis C is probably the one that's responsible that they cannot have tattoo shops in Georgia. Anybody know that? No. You have to go out of state, or you gotta hire a dude to come to your house and just have a tattoo party, whatever. That doesn't happen. Whatever. So, but just be aware also, so your body piercings, tattoos, hemodialysis, high risk population for hepatitis C. I would know that. I would know if somebody who did body piercings and tattoos, high risk for hepatitis C, and then low risk, but it is possible from STIs, maternal transmission to the kids. So we do worry about hep C. It does run with his buddy HIV. So unfortunately, no vaccination. We do not vaccinate for C. We vaccinate for A and D all day long. So high risk for going to conversion to chronic state. Here's an interesting thing. Anybody ever read Current Medical Diagnosis and Treatment? So this is a pretty interesting thing. I don't know why they put this in a medical book, but apparently when people used to box, and there was high risk of hepatitis C transmission. So, there's been some pretty knockdown blowout fights, but everybody's seen UFC anyway. Sometimes the juice get covered in blood. So here's your incubation period, 6 to 7 weeks, usually asymptomatic. AST, ALT is going to wax and wane. It's going to go up, it's going to go down, it's going to do its own thing. So most of this will spontaneously clear the virus, or it can progress to chronic disease. No way, shape, or form would tell it that. But we want to make sure that we get our LFTs, aka our hepatic panel. And then we can order a anti-HCV ESI and then confirm that. The confirmatory, 100% confirmatory, is your HCV RNA. If it's producing HCV RNA, it is replicating. That is active, 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 active. It's going on. And then if we confirm it, we just want to make sure, check a kidney panel, check the urinalysis, because high risk of these people having increased protein in their urine, hematuria, and then we see a drop in their GFR. That's not good. Not good at all. There's your slide for you. Again, HCV RNA confirms the acute infection, and then we see that anti-HCV confirms chronic infection. But it's gone chronic now because we're creating antibodies for that RNA. Antibodies for that RNA. So when you see how that goes for months, and then they slash it off, and it goes for years. So this is like a disease process police going to have for a very long time. So because of that, we reach for some medications. We want to do antiretroviral therapy immediately as soon as we diagnose that. So all those different medications, just be aware of those. What I want you to pay attention to, antiviral, so it ends in a VIR. Ends in a VIR. So pretty high cure rates, but it's going to cost. It's going to cost, based on somebody's insurance, they're probably going to get put on the pegylated interferon alpha 2A and B with ribavirin. Much less of a cost. So maybe their insurance company approves that one, and then if they bill that one, they'll shell the money later. They can get them cured with that. That's what they'll go with. Clinical recovery, 3 to 6 months. So, but it's pretty sad here, which is why we reach.
Do they have the medication in the
They can have complications. Again, we worry about if it's what runs with C.
I meant with the medication, the one that is super expensive.
Oh yeah. Anytime you're on an antiviral, it's going to mess with your immune system. Biologics, antivirals. What do you?
Does the military DOD carry?
Is it the Indian?
Probably. I don't know. I've never had to prescribe it. But so when they hit this point, you're going to be probably seeing hepatologists. I imagine that they have these types of things, probably in smaller amounts, smaller quantities. But that's not something I'm big on my formulary. I will tell you that if they have what they bought for COVID, then I would be probably pretty sure that they're going to have this type of thing. I can't speak to it for myself. I don't remember what the gastroenterology clinic. Any idea of that? No. But I can find out. So I don't know if people at Advancing just say, hey, do you have this on your formulary? There are, they're getting more and more popular with the antivirals and the biologics. So, sorry, I thought you were going to ask about side effects. No. Cash money, yeah. We're not revenue driven, so. And they just started paying for in vitro. They didn't do that stuff years ago. So hopefully we get better. But the VA is a backbone, so I don't know what to say about that. So 80% most highly likely to convert, and then 30% developing, so 1 in 3 developing cirrhosis. That's not good. I'm guessing those 3 things people have been history with hepatitis C. But anyway, moving on. B. So this is a RNA virus. So this is only association with B. So it can typically run with B. So this can also show up at surface antigen as well. So usual drug group, our infection group is drug use. Similar routes with HPV. So if they have HPV, we need to be concurrently testing them for HDV. Okay. So that's all you have to know about that. So These other ones, not very exciting. We really want to be strong on the ABC portion of this. So this is E. This is another one usually found in parts of Asia, Middle East, Northern Africa. So usually endemic area travel, again, fecal to oral. They can have waterborne outbreaks due to contaminated water. And we do get very concerned about these if we have a pregnant patient. So if it's a pregnant patient, we're worried about hepatitis, we're really worried about C. They can progress to fulminant hepatitis. Questions about viral hepatitis besides I owe you an answer to C. I have some pharmacy friends. You know what? Huh, you guys have a pharmacist. Man, I'm tag her with that. Task the troops, task the pharmacist. Find out. You guys gonna get lectured from her anytime soon? No more, you're done? Let's get into chronic hepatitis if I don't have any questions. Hey, 3 months. That's what we're looking at. People go over the 3-month mark. That's what I want you to take from these. So B and B run together. We have C greater than 3 months. So again, we pay attention to that AST, that ALT. So persistent presence of that, I told you that surface antigen, if it's still showing up, and anti-HBC, we are in chronic nature land. And also that anti-HCV. So, and then of course they can go in and biopsy the liver. So, not something I ever want to have done, but sometimes you get that figured out. So, in the absence of them having serious cirrhosis, these people can be very asymptomatic. They are simply just a carrier of the disease process. Maybe we have awesome immune system, this is what it is. So what do we want to stop? We want to stop that viral replication, that first stage. If we can stop that first stage, then it doesn't go on to stage 2, 3, and 4. So secondary gains, we also want to make sure we're taking care of these people symptomatically, giving them medication for whatever their symptoms may be. We do not want that to go to chronic hepatitis, because that chronic hepatitis progresses to cirrhosis, which progresses to hepatocellular carcinoma, and that's no fun. So antiviral therapies for this. So we have that PEG for 48 weeks. That's going to be a lot of money, and then oral nucleosides and nucleotide analogs for 1 to 2 years. Again, I will talk a major part and get you some answers on that stuff. I don't know. You guys are asking about if we have the medication. Who's trying to get this? No? Okay, good. Okay, eradication of that. So when reducing the symptoms, so preventing delay, progression to hepatitis, again, we want to stay away from each of these chronically. And then, again, we can have some extra hepatic complications. We want to keep track of that. So, we have autoimmune hepatitis here, so much more common in women, unfortunately. So some patients, this is an incidental finding, they may be completely asymptomatic. These do run together. If they have an autoimmune other type of disease, autoimmune hepatitis should definitely be someone you're differential. So we're going to see a transaminitis just randomly caught incidentally. Just got some random labs, got some LFTs, they're elevated, what's going on? Then we ask our patient, very non-specific symptoms. So we're in that prodrome phase right here. We just kind of have those different kind of flu-like symptoms mixed with arthralgias in the joints. So progresses to the icteric phase, which is profound jaundice, elevated PT. So regardless of viral versus autoimmune, we still kind of see those same progression through those 4 stages. Okay, extra hepatic manifestations. So arthritis, again, if it's autoimmune, it's going to run with things like Sjögren, thyroiditis, nephritis, ulcerative colitis, hemolytic anemias. Again, either way, it still puts them in higher risk for cirrhosis and cancer. Everybody crystal clear on kind of how that progresses? I know you're going to have to go back, and especially you should be good on A and C. We need to go back and clean up on B. Those 2 charts in there should help you out with working through that. I'm telling you, you are going to have chance questions on hepatitis B, and they're going to ask you very specific questions on antibodies versus antigens and what shows up, and what if they were vaccinated, which one's going to show up, and what if they actually were exposed to the disease, which one's going to show up. Those all change a little bit, and what makes it acute, what makes it chronic. We need to know that stuff. And this is designed to help you. All right, let's see what we got here. Did I ever talk about chronic phase? No. Okay, so beat out. I talked about what starts at its viral replication phase, then it progresses to prodromal phase, then victor phase, and then convalescent phase. So which one is this? So I'm not saying anything about jaundice. I'm talking about these are just kind of flu-like symptoms. So we're in prodromal phase. Good. I didn't talk enough about DNA, so you probably rest assured it's either A, B, or C. But I told you that certain things, when you have the A is usually fecal oral route, B we get concerned, prisoners, sex, and healthcare workers. C, I talked a little bit more about body piercings and tattoo places. So C is going to be your answer. Oh, you're going to have to know these. Gravitas G. So surface antigen, it's just going to give us an idea that they've probably been exposed, and maybe it's replicating, maybe it's not. The envelope antigen would say, oh yeah, they probably had fulminant disease potentially. So core antigen would be if they were actually exposed to the actual disease. But if they were just exposed with the vaccine and they didn't get it, it's going to be D. Maybe D. Go back and look at your slides. It's 100% correct. I won't give you credit if you pick anything else on your test. Maybe. One more. One test that gives you an idea, but there's one test that is 100% going to give you the confirmation. Who do you remember that was? It's like bold and underlined, so I hope we pick Bravo. Thank you. All right, you guys want to take a quick break and then we'll come back and do the second lecture? The break. There's a lot to do with body habits, body choices, those types of things. A little bit of probably hereditary predisposition. There you go. Diabetes, hypertriglyceridemia is part of the metabolic syndrome. So a lot of times we say fatty liver disease, the initial thing is going to be body choices as far as obesity, diagnosed with diabetes, and then we throw in that high triglycerides. How does a high triglycerides affect all of this? You're wondering, okay, it's insulin resistance, so probably sedentary lifestyle. But what is essentially going on here is because of this, it's going to affect the pancreas. It's going to affect the pancreas, and it's going to cause insulin resistance. So definitely association between that and cholecystectomy. That means that it reduces with cholecystectomy. So most of these patients are going to be asymptomatic. This is going to be incidental finding. If they do complain about anything, it would be just generalized type of flu-like symptoms with some right upper quadrant pain. So again, they usually find that and say, oh man, you got elevated liver enzymes, what's going on? And so they'll find the ultrasound that. They have some other cool little scans where they can go up and look for fibrosis and any types of fatty liver disease with a finding right away, but also incidental finding of this. Incidental meaning it's found accidentally, we're looking for something else, and we end up finding that. Because your labs are going to be usually 1-to-1 on AST and ALT, meaning, again, we said it's not alcohol related. Alcohol related, we see a 2-to-1 ratio there. So, but we still can continue to see that outfloss. And we get an ultrasound. The ultrasound for that, we're not going to order necessarily exactly a hepatic ultrasound, but right up front we'll get that done. So, and then sometimes a biopsy, usually with non-alcoholic fatty liver disease, we're not even wasting our time with doing a biopsy because we're not usually going to progress to much more than that because that's typically caused by some life changes or life decisions and then some diabetes and some hereditary things. So, but we do want to make sure that we rule that out with excessive consumption of alcohol. Yeah, most patients aren't going to be honest with you. There are certain lab tests. I'll talk to you a little bit about that later because they've got pretty savvy with all that stuff. So lifestyle changes, diet, exercise, weight loss. How does vitamin E work? Well, it has antioxidant effects on that. Some of this stuff is still a little bit more theoretical, but if you want to do some research on it, you're welcome to do it. And then again, if the pancreas is being affected with those high triglycerides, we need to get some insulin sensitizing agents. Prognosis usually benign course, worse in the elderly, diabetic, high BMI, people that have other comorbidities, and then again, over the BMI over 30 is what's concerning. So please pay attention to your BMIs. Those folks, there might be a higher risk for that. But we'll get into the more exciting part, which is alcohol-associated kidney disease. So this causes dysplastic and inflammatory changes to tissues. That's chronic excessive consumption. Why? Because the liver is trying to clean out all the alcohol from the body. We have these 4 flavors that it kind of progresses, starting out initially with just some fattiness, then we have some fattiness with inflammation with steatohepatitis, then full-on inflammation with hepatitis. What are we probably also going to see that's going to run with this hepatitis if it's alcohol related? What other organ affected? Pancreas, thank you, pancreas. So let's see if we can see those two, and then progressing to cirrhosis. And we'll have to kind of discuss how we stage all that stuff. So again, runs the fulminant from just fatty liver to inflammation more, and then eventually to hepatocellular cancer. This is what probably got Toby Keith, maybe Patrick Swayze, I don't know exactly, but just to give you some ideas, this does happen to people. So 90% of heavy drinkers are going to have fatty liver that is related to alcohol steatosis. So 1 in 3 will develop the next level, they continue to drink, and then 8 to 20%, that's pretty wide percentage, so I wouldn't put too much faith into that. But if they have that, then they'll progress to cirrhosis. But anywhere from what 1 in 10 to 1 in 5. So here's that progression for you. Normal liver, you keep drinking, keep drinking some more, progress to inflammation, then we get fibrosis, it starts scarring itself in, then cirrhosis, and then that cirrhosis will transition to cancer. So, fatty liver, so again, may just be incidental finding again, they have no symptoms. I guess they're giving you some more validation on why you should be percussing the liver to determine its size. So, but 2-to-1 AST, similar to how we see with alcoholic issues with that. The AST is going to be doubled. We saw about that with liver disease, alcohol related. Following that with the GGT, let's refer them to get an ultrasound and probably a biopsy. Why are we looking at getting that biopsy? We need to see how much inflammation is going on and has that progressed to hepatocellular issues or progressed to cirrhosis yet. We want to get an idea of that. Maybe we can turn the corner on these folks and get after getting them fixed. So they're going to do that biopsy and it's going to be sent to a pathologist who's going to be able to look at that and decide what is that. Is this just steatosis? Is just steatosis with hepatitis? Is this going to a cirrhosis versus a carcinoma? So progresses. These people can show up. We're having jaundice. We're going to see the jaundice at first and the sclera, but they're also going to have anorexia. These people are chronic alcoholics, so they probably don't eat very much, but they can get fevers, and they can have hepatomegaly. So older people who have hepatomegaly, you need to be concerned about fatty liver, whether it's alcoholic or not. When you have kiddos that have hepatomegaly, you need to be worried about leukemia, just to give you an idea. But there we go, 2 to 1. We know that's alcohol related because we're having that bump in the AST, but we're also seeing the ALT go down because of what vitamin is being deficient? Remember that from before, B6? Okay? B6. So you start seeing these older folks, they start getting muscle wasting. Why? Because all they're doing is drinking, they're not working out, and have distension with or without ascites, or ascites with or without abdominal distension. We see that 2 to 1 again. We're also going to see bumps in the bilirubin, the GGT. So leukocytosis, that's a natural inflammatory response for the body as they're having significant inflammation because of that alcohol to the liver. And then again, we see elevated INR, which means we also probably have elevated prothrombin. So we need to get these people to abstain from alcohol. So monitor their alcohol withdrawal. You're going to go to their house and see them, monitor their alcohol withdrawal. Now, well, we do need to think about what we can give these people for their withdrawal symptoms. So benzos. You may have heard of a drug called Librium. I'm not going to test you on this, but Librium is like the top medication to give somebody so they don't go into alcohol withdrawals. They don't go into DTs. They don't go into seizures. They don't have those cravings. Great medication to get them out on. Not something that, and if they drink on it, they're going to be retarded. I kid you not. Like it's completely off the mental status. So, we need to pay attention to that, getting these people on rehab and stuff. So, they got to a new lab test where they can test whether or not you have drank for the past 2 months. Similar to cocaine where they take a hair sample. So they don't need to have that ethanol level. They get something called a PEth, and they can tell based on your levels. So if you're below 20 on that PEth, they say that you have very low intake or have been abstaining. Moderate 20 to 210 means you have moderate consumption, and then if you're above 200, so you have excessive consumption. When I say over 200, I've seen people in the 500s. 500 is like a 24 pack a day kind of person, or at least a couple of fists, just to equate that in there. Because you do have to have people, how many beers do you have? You say, like 3. And you tell me they were 64-ounce beers. To equate that sometimes. But just to give you an idea, if you really want to help these people, there's other lab tests that need to be done. So to not get on a high horse there, you may not catch an ethanol level, but you get a PEth level, you can determine that that person, they are having alcohol-related liver disease. And we need to probably have a full court press on them with counseling, CBT, and potentially inpatient rehab. And then be concerned there's a whole bunch of other things that are going to run with that as far as obesity, insulin, malnutrition, smoking, viral hepatitis, and those people that drink, that's a gateway drug, they're going to get into other things too. So potentially bringing that person in, if they have decompensated cirrhosis, you run the risk of hepatic encephalopathy, respiratory failure, hemodynamic instability, and shock. So, and we look at those people, we should tell them 1 in 3 chance of mortality of 1 year, and if you continue to drink for the next 5 years, that's up to 85%. That's pretty sad. But it didn't stop this guy. Anyway, we get into cirrhosis. So cirrhosis, late stage of that. So again, that cirrhosis is right before we pass into the cancer realm. So we're going to see fibrous changes, vascular remodeling. It's usually something that you're going to find on either an ultrasound, CT scan, and then we have the formation of regenerative nodules. So there's a lot of different nodules that are going to form. These are the liver is trying to set itself up for success. It's just a side effect of that amount of alcohol that's going in there. So there are other things that can progress to that cirrhosis. I know we talked about alcohol fatty liver, but we also need to be concerned about our viral hepatitis, with C and B being the ones that cause that. So non-alcoholic fatty disease can also progress to that. So that's what we worry about our diabetics and our people that are very obese. And then we have something called hemochromatosis. So hemochromatosis, what does that mean? Typically you're going to see elevated HMH, but what's happening with those folks is they're absorbing too much iron from their food. Too much iron from their food puts them at high risk. There's an iron not supposed to be that much iron in the body. So This is associated, if you were to see if it is related to alcohol, they call it micronodular. That's what you're going to read on a radiologic study, micronodular. So, and then we see how it progresses through the stages. So they're going to compensate, they're going to be able to handle this. The body, the liver's going to try and regenerate itself, and try and fix it. I think it's going to progress to varices, still compensated, but those varices haven't ruptured. It gets worse, it starts backing up, portal hypertension causing ascites, variceal bleeding, encephalopathy, and then eventually jaundice. So that's all from the combination of the dysfunction specifically at the hepatocyte, as well as that portosystemic shunting and portal hypertension, and then it just progresses out of control from there. If it's compensated, they may or may not be symptomatic. So a lot of these folks, because they are hardcore drinkers, if that's what the cause is, they're not going to come in to see you because they don't want that to stop. But it's going to run with non-specific symptoms. We're going to see anorexia, weight loss, weakness, fatigue. And then it starts getting decompensated. Now we're going to see spillover of bilirubin causing jaundice. We're going to see extra hepatic type of symptoms with pruritus, progressing to vomiting of blood, potentially seeing melena, which is blood kind of mixed in with the stool. Hematochezia would be bright red blood right at the rectum. So typically we see ascites on these, and progressing to hepatic encephalopathy with significant confusion. So this is just a schematic for you, just to show you all the different side effects that this can happen. Just for you visual folks, I'm not going to pull any questions off of this. Got a few more pictures for you. So you see that pretty significant abdominal distension. That is ascites. You should be able to see that from a mile away. I will ask patients or somebody there, like, how bad is this today on a scale of 1 to 10? Because these people will fluctuate back and forth. And if it's feeling tight and they're like, oh, it's never been this bad again, if I need to be admitted and get that, it creates a lot of problems. But then we also have a lot of systemic problems with this as well. So we're actually going to see a drop in the blood pressure, So they become normotensive. What's the worst was once was hypotensive, this is normotensive. This means the body is starting to fail itself, including fatigue, fever, weight loss, and muscle wasting. So we're going to see these in our cirrhotic patients. So we have that vasodilation that starts to occur because we've had so much scarring to the liver that the body is compensating on the rest of the vasculature by vasodilating. This causes a decrease in the systemic vascular resistance and arterial pressure. So essentially, we're going to see a reduction in arterial blood flow. And what happens? What's going to take a hit? Now the kidney's going to take a hit. So the kidney's going to try and fix itself by vasoconstriction, by retaining more sodium, by trying to keep that going on. So what's going to happen there? It's vasodilating, and now the heart just has to keep up. And now we can run with a supply and demand stemming potentially. So we're going to have an increase in heart cardiac output to compensate for all that vasodilation, while the kidney's trying to vasoconstrict and hang on to as much blood and filtering as it can. So you can see this just creates a very significant, nasty picture. Again, ascites, hepatomegaly, sphenomegaly, then we have this caput minusae, which is portal hypertension, cause all these veins in the abdomen to vasodilate. So, and they're starting to scar in, so pretty nasty. Immune system's being shunted. I'll show you a picture here in a minute. But then you have Creville higher, Baumgarten. So that's a listening down there in the abdomen. So portal hypertension creates a venous hum because it's just getting turbulent as it's pushing on the blood flow through there. So stethoscope placed on the epigastrum. So you should already see some ascites and potentially see this. That's what that looks like. Obviously named after Medusa. What's our other systemic manifestations? Obviously, jaundice. If you see in a stem that they're having spider angiomata, we need to be very concerned that that's underlying cirrhosis that's happening. Underlying cirrhosis, palmar erythema. I got a picture for you, and then we're going to talk about these weird nail findings. So I've never paid that much attention to people's nails, but checking cap refill. But here's some other things that can clue you in to knowing that there's other things going on along with nail clubbing. I'll show you some pictures here. So there's your spongerage angiomata. So telangiectasia is what that is also referred to. And we have palmar erythema. So Here's your clubbing, so, and your meningeals. So what you see there is just lines that are going through that. Horizontal lines, these are pale horizontal lines on fingertips indicating that there's an underlying disease. So these are showing that they have had low volumes of albumin in the blood. So typically that's related to either hepatic or kidney. And then we have these pteryneals as well. Pteryneal cell, medical condition where it appears white or ground glass, and then it has a narrow band of pink or brown in it. And this is just a sign of aging, but typically cirrhosis is an underlying thing that we keep on the differential. Now we do with endocrine as well. So unfortunately, anovulation is common for women. Now that can present as either amenorrhea, meaning no menstrual cycle, or irregular menstrual bleeding, whether that's metromenorrhagia or whatever. So hypogonadism in gentlemen, decrease in sex drive and testicular atrophy, potential for them to lose their armpit hair as well as their chest hair, and then gynecomastia. I've got a picture here for you. So that's not normal for gentlemen. There's a bunch of other things that you can look up. You should have a pretty stigma wide differential for gynecomastia. Some people say marijuana use and certain medications can cause that. Here's another wonky one. Not that I go smelling everybody's breath, but you guys have to do it for your whole man. Hopefully no more for you guys. But this is a sweet, pungent smell to the breath. So, similar to fruity breath for a person in DKA, but what happens here is because of the metabolic changes in the liver, it's not breaking down all the compounds that it should normally. So this is what is left over and it gets released in the breath. So and then carotid gland enlargement, this all has to do with just infiltration, edema, and inflammation that's happening across the body presents in that as well. Then we start getting into the sad world, and that's hepatic encephalopathy. We'll talk about that a little bit more. But asterixis, anybody ever seen that? You can look that up on YouTube. I guarantee if you've not seen something in life, it's good to have an idea of what that looks like. So these people put their hands out like this, and they dorsiflex, and they just kind of rhythmically go back and forth. Not anything that they can control. Very, very interesting type of thing. It probably has a lot to do with electrolytes and whatnot. And now everybody's putting their hands out, making sure they don't have hepatic encephalopathy. So thank you for that. Early, nothing big. And when we start seeing that, we throw the kitchen sink, thrombocytopenia due to enlargement of the spleen. We're going to see anemia. Again, a lot of these people are drinking too much, so we're going to see folate deficiencies or GI blood loss from varices, and then leukocytosis or leukopenia. That can be either due to they have underlying infection or they're having some hypersplenism. Other serum chemistries, these people are drinking, they're not taking care of themselves. There's not a lot of salt in alcohol. So hyponatremia, increase in BUN and creatinine because the liver should be taking care of that, and it's not. And then ammonia accumulation is one of the worst things that we're going to start seeing there. So again, they're drinking, increased AST, ALT, alkalos, GGT, bilirubin, PT, decrease in albumin from the inflammation. So we get an ultrasound to confirm, yes, it's shrunk in irregular nodular. So that's what it's going to say. Findings associated with, and they'll probably stage it for you with this bad evidence of cirrhosis, which is getting all nodular, it's getting fibrotic, and it's not normal. And we want to go and biopsy that. And then EGD, definitely within their future, because they want to go in and see how bad their varices are. Maybe they had that complete medusa, it's great. If that's there, I guarantee you varices are there, but not everybody's going to present that way. They need to be scoped and go in there and look at those varices. Refer to GI if you're in a big enough hospital that has a hepatologist. That's great. There will be somebody that's assigned that will take the role of the hepatologist, but they are GI trained. We've got to reverse or progress that. We need to prevent them from additional injury, so we need to be very careful. So if you have somebody that has underlying cirrhosis, you might need to pick up the phone and call your pharmacy and say, hey, I want to give them this medication. Is that going to be a problem with their underlying cirrhosis? You have to do the same thing with people that have chronic kidney disease too. You gotta call them because they may need to be hepatically dosed, they may need to be renally dosed, or they may not need that medication at all because it's gonna cause too many problems. So I wanna treat any of the complications with this, and then obviously liver transplant. And that lab that I told you, the PEth, they can tell if somebody's been drinking for the past 2 months. If they're on a liver transplant list because of cirrhosis, guess what lab is somebody's gonna test them? They're gonna do that test. Guess how quickly they're gonna rip them off the liver transplant list? Bam, gone, see ya. We're not giving you a new liver, you didn't like the one you had in the first place. So, again, treatment, abstaining from ETOA, sure there's other medications out there for that, liver to bring them off with withdrawals, and then we potentially everybody heard of antabuse. Basically, they drink alcohol, makes them vomit. I think that's kind of archaic, but whatever. Make sure they're taking care of their bodies, and then if they've not been immunized, maybe they need to be immunized with covering A, B, pneumococcal vaccines, even a flu shot. We don't need to mix this up anymore. And ultimately, a liver transplant if we can get them that far. So, I told you that peptic ulcer disease is our first cause of upper GI bleeding, most common, and number 2, concerning for varices, which is gastrointestinal tract bleeding. We're very concerned about these folks with underlying liver failure. At any point, they're likely immunocompromised, especially if they continue to drink, and then that can progress to spontaneous bacterial peritonitis. We will talk about that later. Hepatorenal syndrome I'll come up with here in a minute, and then encephalopathy, and then preventing or progressing all the way to hepatocellular carcinoma. Very concerning. So here's your hepatorenal syndrome. 1 in 10 with advanced cirrhosis. End-stage sequence of renal perfusion. So the liver's not working anymore, and it's vasodilating. Now the kidneys are starting to fail. Poor prognosis with this. How do we know the kidneys taking a hit for that? We're going to see a bump in our serum creatinine up to 1.5. Remember, serum creatinine goes up, GFR goes down. It's going up. That means we're getting in the realm of where we're having chronic kidney disease, progressing potentially chronic kidney failure. So, azotemia, so that is elevated levels of nitrogenous waste products in the blood. That means that the liver is getting up and other organs are going to start to follow. So we see they can't produce urine, they're hyponatremic, low sodium concentrations, not good at all. So we need to get that liver function doing much better so it can take over and start doing what it's supposed to do. So we need to also reverse that acute kidney injury. How do we reverse acute kidney injuries? Initially, right after that, what's the first thing that we do? We need to hydrate that person. It's probably IV fluids. Not going to be like, full blast or anything, but maintenance IV fluids to slowly weigh that kidney back in. Because once it fails down, they're on hemodialysis. And 3 days a week in hemodialysis clinic is no way to live. But they need to monitor ICUs because they're monitoring eyes and nose, inputs and outs. So, and then making sure we don't progress to this. So, it's a neuropsychiatric abnormality with hepatic encephalopathy. So, we see anywhere from 3 to 4.5 out of 10 patients that have that. So, buildup of ammonia is what causes that. Buildup of ammonia. The kidneys, the liver cannot get rid of the ammonia. So, cannot get rid of it, cannot clear it. It builds up and builds up. These people are in bad shape. So, mental status changes on a whole bunch of different levels. Looks very much like Alzheimer's. I need you to know that the most common initial manifestation is sleep pattern inversion. These people just completely flip the script on the normal circadian rhythm. I get up at 7, I go to sleep at 10. I'm waking up at 10 and going to sleep at 7. So that is going to be the first manifestation. Do I need to say it again? Don't put on my porcine valve that I'm repetitive. You're just going to pick this. You pick something wrong, pick something I didn't even talk about. All right, beware that one. Other physical exam findings, so they are slow. They have the asterisks I talked about, slurred speech. This is not because they continue to drink alcohol. No, this is because this is what happens. Nystagmus, all these manifestations start coming up. They grade that on this scale right here. I just I'm not gonna grade you on this, I just want you to realize that they look at 4 different main categories. There, they have to do with personality, the level of consciousness, and as they progress with this ammonia level that goes up, all these types of things just get dumbed down and get pretty bad. So these people have to be admitted, and be protein restricted, need to be put on fluids. The mainstay of treatment is these people need to be put on lactulose. Lactulose is the main medication they're going to reach for. There's other things that we can reach for, but I need you to know that lactulose. So, and then they're probably going to bring a nutritionist in and put them on pre and probiotics to help out. Your MELD score, what I want you to take away from this MELD score, I'm going to put this into MD Calc and let it crank it out for me. But you look at that, that's just a combination. They have all these cool numbers that they figured out that come out to an idea of how bad that end-stage liver disease is. But obviously it's going to take into account the INR, the bilirubin, creatinine, all things that are increased means that bad stuff's happening. So just know the higher the MELD score, the worse prognosis. Some other hospitals may use this one. I'm not going to test you on either of those, but I just want you to be aware that there are 2 different scores, and if you're going to call somebody with out there as having significant liver disease, you need to talk to a GI doc who's probably going to say at the end, well, what's their MELD score? So he may ask you for what's this one, and you'll be ready to go. This is a more questions here, and then we'll get you folks moving. Hemochromatosis. How do we treat it? What's the first line for treating this? Well, they're holding on to too much iron, so giving them more iron is out, whether even that's oral or through IV. So we're down to B, C, and D. What is deferoxamine used for? Anybody have any idea of that? That's not going to help out. That's iron-no-risk if somebody takes it orally, little pills. We need to bleed these people. I imagine back in the day it was done with leeches, but now we do it with full body. They will bring them into clinic, take off a liter or 2, and see if that helps them out. Kind of work. Sounds very archaic, but not much else we can do to get these iron sources to drop. I did talk about hepatorenal, I didn't talk about thiamine deficiency, I did talk about poor occupancy. No way, shape, or form did we talk about Wernicke-Korsakoff syndrome. So, but if they're having asterisks, what I talk about was a big thing with that. E, hepatic encephalopathy, right? All right, good to go. Questions, concerns, I'll be up here. Not too shabby.